You're watching Ketome TV. Knowledge is power.
I would like to turn it over to you. You're going to share with us about small cell lung cancer today. And that's something I know absolutely nothing about. So
Yes.
I'm interested to hear what you have to share with us.
Okay. Well, as you know, last week we did non-small cell. So I think it's a good idea that we cover a bit of the developments in small cell. I think we definitely do have patients calling us saying, okay, we hear all about non-small cell and, all these wonderful and amazing new advancements. What about small cell? So just a little bit about small cell to start out with. It's about 1/3 of lung cancers,
Okay.
Yeah, a small percentage. Probably, 1/3 to a little less. And they're often referred to as neuroendocrine tumors of the lung.
Help us understand neuroendocrine.
Yeah, so endocrine cells are cells that excrete different things, proteins, enzymes.
Okay.
And, they form a type of cancer.
Oh.
Now, they were originally described as oat cell cancers.
As in eating oats?
Yes, oats, because the cells occupy this shape that it's like an oval shape. Under a microscope, they have an oval shape, and the cytoplasm is really small in these cells. So, they have this kind of shape of an oat, a rolled oat.
Interesting.
Yeah. So the types are, there's what we call low-grade carcinoids.
Okay.
Then there's intermediate grade carcinoids, atypical carcinoids. And then there's two high grades, which are the standard small cell and large cell neuroendocrine.
Okay.
They're caused by heavy smoking, almost specifically. It's one of the most common.
Any one of those four types is smoking related?
Small cell cancers, small cell lung cancers in general.
Okay.
Yeah, they're caused by heavy smoking.
I know I've heard you say, when you talk about smoking, I know I've also heard you talk about, people who work in environments like, say, firemen or people who work in certain cooking environments. Is that true for this type of
No, this is more smoking. More carcinogens involved in tobacco smoke. Yeah,
smoking.
It is, yes. It's not, they have a poor 5-year survival rate. I think it's less than 7%.
Wow.
Yeah. And so that's probably due to the genetics of them. And so the genetics, they have a high frequency of gains and losses of pieces of chromosomes and genes. They have one of the highest mutation rates out of most tumors. And they commonly are driven by what we call epigenetic regulation. And so I think we should probably talk a little bit about epigenetics.
Yes, please.
So what epigenetics is, you hear people talking about epigenetics all the time these days. It's a process where our body uses the same genome to create different cell types.
Okay.
So epigenetics is differently the process of turning certain genes on and off in different tissues.
To create different types of cells.
To create different types of tissues, yeah. So you're using the same set of genes. You're not changing the genes. You're just changing the regulation of these genes.
And this happens during my lifespan. It's not, and that's what's so cool about it, is that my DNA is changing as I live, as opposed to
it's an adaptive process.
Okay, and how does the epigenetic regulation pertain to the small cell lung cancer again?
Well, certain genes are turned on that are not supposed to be, oncogenes, and certain genes are turned off that are not supposed to be, tumor suppressors, rather than just being damaged as they are in other cancers.
Right, and because, and that's what you were saying earlier about there being a fairly high percentage of mutations in this type of cancer.
Yes, that too, yes, yes. So the process of epigenetic regulation is based on what we call methyl and acetyl groups. And they're attached to the DNA, and they prevent the transcription material or transcription machinery from accessing the DNA. and opening it up.
Right.
So there are drugs that target certain processes, but they're not very specific. Certain processes of epigenetics, but they're not, demethyltransferases or demethylases and so on. But they work on a global level. In other words, they work on all of the DNA at once, so they're not that effective. They're more random, if anything.
So this is new, this field of study.
Yes, definitely.
So, and given what we've seen in the last, well, you decades, me 10 years, what you're talking about right now is not being very specific, is almost certainly going to get a lot more specific and a lot more targeted.
Yes, over time. Yeah.
Okay.
Yeah. And I think, we're going to start incorporating epigenetic features into.
It's going to be an important part of the diagnostic process.
Yes.
And so what would we do? How would I tell whether that was happening for me and driving my...
Well, right now, for example, in a disease called glioblastoma multiforme, we can test certain genes to see if they are methylated. And if the promoter region is methylated, then that means that gene is not functioning. And that can be indicative of whether certain treatments will work or not.
Right, yes. And what kind of test is that?
That just tests the promoter of the gene, the activation region, for its degree of methylation. How many methyl tags it has on it.
Okay, that sounds like important information.
It is, yeah. It's a good test for that disease, yes, for sure.
And that's not the same as the like a genetic panel test.
No, it's very different.
It's a completely different thing.
Yes.
Wow. Okay.
Yeah. So in these cancers, we see a lot of specific mutations in tumor suppressors. Two of these tumor suppressors, P53 and RB1, retinoblastoma gene. I believe P53 is mutated in up to 90% of small cell lung cancers.
Did you say 90%?
Yeah.
Wow.
Yeah, it's quite a bit.
Yeah. And what can we do if my P53 is mutated?
Not much.
No?
No.
Seriously?
Yeah, unfortunately. Yes. Yeah, it's the guardian of the genome. And
so that's why the survival rate for this type of cancer is so low right now.
Yeah, so these cancers actually respond really well to chemotherapy because they have a high burden of mutations. But what happens is they relapse very quickly. And so that's why we have the small survival, 5-year survival rate. So they have a high metastatic potential, definitely spread. And poor clinical outcome, as they call it. So the first line of treatment is typically cytotoxic chemotherapy drugs. So they have really good response rates to these, 50 to 70%.
Okay.
But patients relapse very quickly.
Right. Because there's so many mutations.
Yes.
Right.
And they evolve at a high rate and mutate at a high rate. So.
You're not going to do that, right? It's all on the back end here. We're seeing a few ideas Alex is having that were probably not a great idea. Okay, sorry. You're great with cancer, but
notes and stuff. I don't know what to do with them. Just drop them on the floor.
Yeah.
Let the dog pick them up.
Preferably not. Okay, so you were saying 50 to 70% of people do respond well to the cytotoxic chemo, but it doesn't last very long, that response. Exactly. And then what?
So there's basically two approaches. So there's the platinum-based and etoposide. So cisplatin, as you know, is a platinum-based drug. It interferes with DNA replication, and it's combined with a drug called etoposide, which is what we call a topoisomerase inhibitor. And so, interesting enough, topoisomerase is the enzyme that opens up the DNA strands so they can be copied during replication. So it can be considered part of the epigenetic process because it's involved in opening up the DNA directly. And so these drugs, etoposide, actually interferes with its ability to open up the DNA and transcribe, so the cancer cells can't copy their DNA. The other one is carboplatin, which is another platin drug, and that's combined with etoposide too. And then for later lines, they can do things like cyclophosphamide, which creates cross-links in DNA, and doxorubicin, which is a topoisomerase 2 inhibitor, and then vincristine, which is actually a vinca alkaloid. It's from the Madagascar periwinkle, I believe. Yeah, it's naturally occurring, and that interferes with the tubulin that separates the chromosomes. So these are all common chemotherapy drugs. So those three drugs are combined together, and they can be somewhat effective.
Okay. Now, okay, but just so I'm following you, these are second line options.
Yeah.
Now,
the last one's the second line.
Now, why would that not be offered initially?
Well, the cisplatin and the etoposide are first line.
Oh, are they?
Yeah,
okay.
the platin and etoposides are first line typically, and then this triplet combination of cyclophosphamide, doxorubicin, and vincristine.
Oh, vincristine.
Yeah, that's the second line. That's the average standard second line. Now, some doctors may give, a platinum drug as a second line, or, may change it up a bit, but.
Okay. All right. Now you're going to tell us there's more, right?
There is.
Okay, good.
Yes, we have some faves that we like.
Okay.
Some recent faves.
That help to boost that 7% number.
Yes.
Yeah.
Definitely. So we focus on later lines, obviously, because most of the patients come to us at a later line. They've already been through chemo, and patients have a really good response to first line chemo. So we focus on the later lines. So PARP inhibitors, olaparib, and a drug used in glioblastoma multiforme called temozolomide. When you combine those, interesting enough, temozolomide can be used for small cell lung cancer. So when you combine those two drugs, olaparib is a PARP inhibitor. It's typically given to patients with BRCA1 or 2 mutations.
Yeah, tell us, for those at home and myself included, PARP inhibitor. What's the PARP?
PARP is it's a protein, more of a signaling pathway that is involved in DNA repair.
Okay, so a PARP inhibitor
inhibits the PARP enzyme.
Okay, and this is good because if I have this cancer, that's been taken over by my cancer cells.
Yeah, so when you have a mutation in a DNA repair gene, such as BRCA1 or 2, or even ATM, or some of the other genes associated with BRCA1 and 2, then what happens is you can create this circumstance that we call synthetic lethality. And that is where you're already missing part of the process of this repair pathway. And then when you inhibit PARP, you're also inhibiting its backup pathway.
Right.
And so then the DNA has no way of repairing itself, and the cell basically dies from that.
And that's something I know you've talked about with people with inherited mutations.
Right.
If they have an inherited mutation that's intervening in a natural process like that, and then through their life experience, they get another mutation over here.
Yes, that's a double hit. Yes.
Yes, and that's what you're talking about
it's
here.
Similar process, yeah.
Okay. So right now, you're still going to recommend for this type of cancer chemotherapy as a first line?
Well, it depends. Depends on what mutations the patient has.
So
there could be some targeted options there. Definitely, you want to look at everything.
Right. So if there are targeted therapy options, that would be great.
Yes.
Otherwise, if they don't have that data yet, or we would do the chemotherapy.
Correct.
Right.
Correct.
But the backup plan gets better.
Yes. So as in with all cancers, we have to look at immunotherapy here. it is a lung cancer too.
And what makes you say that? Why does that have anything to do with it?
Well, lung cancers have been recently approved. In fact, recently the FDA, as of June 17th this year, the FDA has approved pembrolizumab, a PD-1 ligand and receptor inhibitor for small cell lung cancer with progression after other therapies. So this is a indicated drug combination or monotherapy.
So pembrolizumab,
pembrolizumab,
a form of immunotherapy.
Yes, it's
okay.
It's the second PD-1 inhibitor drug ever.
Okay, and
created.
it is approved for use with lung cancer now.
It is as of June 17th.
Excellent.
For small cell. It's been around for non-small cell for a while, but just recently it was approved as a monotherapy for second and later line.
Okay.
And so that was based on two studies, the Keynote 158 and the Keynote 028, which is an earlier trial. So the average response in these patients, and these are late stage patients that don't have any treatment options, the overall response rate was just under 20%. Okay. It went as high as 29% in some patients.
Okay.
Most of it was not complete responses, mostly partial responses, as we see with chemotherapy. In other words, not every tumor is going to respond or shrink, but most of the, a lot of the tumors will respond and shrink, but there'll be a couple stubborn ones that just won't be affected by it.
And the indicator there is that there are other molecular drivers.
Exactly. Or they're not being regulated by the PD-1 pathway at that point in time. Right. It's a transient process, and there's many different ways that tumor cells can alter or inhibit the immune system.
I see. Right.
Many different signaling pathways.
So you just said at that time.
Exactly.
So if I come back around with pembrolizumab,
you never know.
It could be helpful.
Exactly.
Right. But that's where the genetic testing comes in.
Of course.
Because you have to know that that's the right target for you.
At that time.
Yes, that's right. And that's where the exosome-based liquid biopsies come in.
Yes.
You can see if there's more or less of that particular
mutation.
Right.
Helps you find the driving mutations. Exactly. So there was, I believe, 2% of the patients in these two studies on average had a complete response. That means complete response, cancer-free, and that's it.
2%?
Yeah, so that's like a cure.
So that's good for those 2%.
Yeah, definitely. And 17% partial response. Okay. So 94 of the patients had a response of 6 months or longer, which is really good for late stage small cell lung cancer. 63% had a response of 12 months or longer, and 56% had a response of 18 months or longer. And so I think the maximum response in this study, in the Keynote 158, was about 36 months, which is still really good.
3 years, because as you say, this is late stage. They've already had other treatments.
Getting 3 or 4 years on top of that is really something for small cell.
And these types of treatments are.
And this is monotherapy.
Right.
This is not a combination. This is a single agent drug with reduced side effects compared to standard chemo.
Yes. All right. So that's great.
Yeah. And so then there was also another study using a newer PD-1 inhibitor called atezolizumab. And this is combining it with chemotherapy, which really seems to be the way to go for a lot of immunotherapies, is to combine it with chemotherapy. Now, this is actually used as a frontline treatment. And it was recently shown in the Empower 133 trial. And what they found was that the progression-free survival, when they used it up front, was 5.2 months versus 4.3 in chemo. And so basically that, that shows how well the chemo works, and basically shows that this combination improves the chemo slightly. So, relatively new data. So the overall survival was about 12 months, 12.3 months, and then for frontline, and then 10.3 in just the chemo alone. And so that was compared to carboplatin and etoposide. So now these are patients with heavy metastatic disease.
Okay.
So these aren't the average patient. These are highly advanced patients at diagnosis.
Okay, right. So
Very
they're pretty
sick.
far along.
Very sick, yeah. They didn't have a long time to live.
Okay.
Thank you for watching Ketome TV. Subscribe below and stay informed.